All right, let's dive right in. Today we're tackling a topic that's, frankly, one of the most critical and high-stakes areas in all of cardiology: ventricular arrhythmias. These are the life-threatening rhythms that demand you know exactly what you're doing, and fast. So to make sense of it all, we're going to need a really clear step-by-step approach. Let's get to it. Here's how we're going to break it all down. First, we'll start with the absolute basics. What even is a ventricular arrhythmia? Then we'll dig into the why. What causes them? After that, we'll cover how we diagnose them, and most importantly, how we manage them, both in an emergency and for the long haul. We'll wrap it all up by connecting the dots on prevention and some key principles you've got to remember. So, first things first. When we use the term ventricular arrhythmia, what are we actually talking about? Let's get a solid definition and really understand why this is such a dangerous situation. Just take a look at this ECG. I mean, that is obviously not a normal heartbeat. It's incredibly fast. And those electrical shapes, the QRS complexes, they look wide, bizarre, and just wrong. This right here is ventricular tachycardia, or VT. And when you see this on a monitor, it's an immediate all-hands-on-deck call to action. Okay, so here's the formal definition, and there are really two parts you have to lock in. First, the origin. These rhythms start down in the ventricles, the big main pumping chambers of the heart. And second, its appearance. Because it starts there, it creates that very distinct, wide QRS complex on the ECG. That's the unmistakable electrical signature we just saw. So why is this so incredibly bad? The easiest way to think about it is as a simple plumbing problem. When the ventricles are beating that fast, they literally don't have enough time to fill up with blood between beats. And if no blood gets in, then no blood gets pumped out to the rest of the body. That massive drop in cardiac output is what makes a patient's blood pressure disappear and what makes them lose their pulse. That's what we call hemodynamic collapse, and if you don't stop it, it leads directly to sudden cardiac arrest. And the patient feels this lack of blood flow in some very predictable ways. They might feel their heart just racing out of their chest, they might get super dizzy, or they could even pass out cold. That's syncope. When you really think about it, every single one of these symptoms, the dizziness, fainting, shortness of breath, they're all direct results of the brain and the body being starved of that vital oxygenated blood. Okay, so we've nailed down what a VA is and why it's such an emergency. The next obvious question is, what on earth causes this electrical chaos to begin with? Let's really dig into the why and the how. The causes really fall into three main buckets. The biggest one, by far, is structural heart disease. The classic example is scar tissue left over from a previous heart attack. See, scar tissue is not like healthy heart muscle. It can't conduct electricity the right way, and that creates this unstable electrical environment that's just a perfect breeding ground for these dangerous rhythms. Then you have inherited genetic conditions. And finally, there are reversible causes, like a really low potassium level or a bad reaction to a drug. So, how does a scar actually make the arrhythmia happen? Well, the most common way is something called re-entry. Picture an electrical signal coming down and hitting that patch of scar tissue. The scar creates two detours around it, a fast lane and a slow lane. Now, a premature beat comes along at just the wrong moment. When the fast lane is still recharging, it's refractory. So the signal gets blocked from the fast lane and is forced to take the slow route. But here's the key. By the time it gets all the way around the scar through that slow lane, the fast lane is ready to go again. So the signal travels backward up the fast lane, creating this continuous, self-sustaining short circuit. It just goes round and round. So let's do a quick recap of this section. VAs are dangerous, fast rhythms from the ventricles. They're usually caused by scars in the heart, and they keep going because of an electrical short circuit called re-entry. Simple as that. All right, we know what they are and what causes them. Now let's put on our detective hats. How do we actually go from a patient who feels terrible to a firm, confident diagnosis? This right here is probably the single biggest diagnostic challenge when it comes to fast heart rhythms. You see a fast, wide rhythm on the ECG. Is it the real deal, ventricular tachycardia? Or is it a less dangerous rhythm coming from above the ventricles, an SVT that's just taking a weird path down and looks wide? Getting this right is a life or death question because the treatment for VT is way more aggressive than for SVT. So, we use a bunch of clues to tell them apart. As you can see here, a patient's history is a massive clue. If they've had a heart attack before, you should be thinking VT. ECG features, like a really wide QRS complex, also point towards VT. But the single most important rule, the one thing you absolutely cannot forget, is right there at the bottom. When in doubt, you must treat it as VT until you prove it's not. Getting this wrong can be a fatal mistake. To figure it all out, we've got a whole toolkit at our disposal. The 12-lead ECG is, of course, ground zero. It's the most vital first step. If the rhythm comes and goes, we might use a Holter monitor to try and catch it in the act. An echocardiogram, a heart ultrasound, is absolutely essential to look at the heart structure and how well it's pumping. To get an even better look for that subtle scar tissue, a cardiac MRI is really the gold standard. And of course, we might do an angiogram to make sure there are no new blockages causing the problem. So, the diagnostic plan is pretty clear. You always start with an ECG. Your biggest challenge is not getting tricked by that mimic, SVT, with aberrancy. And your guiding principle through it all is to hunt for the root cause, which usually means finding some kind of structural problem with the heart. Okay, diagnosis is made. Now it's go time. Let's talk about management, and we'll split this into two parts: what you do in the immediate emergency and what the long-term game plan is. For a patient who is unstable, meaning they have low blood pressure or they're not responsive, there is absolutely zero time to waste. If they have a pulse, they need an immediate synchronized shock to reset the heart's electrical system. If there's no pulse, well, that's cardiac arrest, and you're starting full-on CPR and defibrillation. In these critical moments, electricity is the answer. Medications are secondary. Now, once the dust has settled and the emergency is over, our focus completely shifts to long-term prevention. And this is built on three main pillars. Number one, and this is the most important, treat the underlying problem. Fix the coronary disease, manage the heart failure. Number two, we use drugs like beta blockers to help keep the heart's electrical system quiet. And number three, we bring in the heavy-duty technology, devices, and procedures. The drugs we use fall into different classes based on exactly how they work. You've got class 1 drugs that block sodium channels, class 2 are those super important beta blockers, and class 3 drugs, like amiodarone, block potassium channels. Each one of these is targeting a different part of the heart's electrical cycle to try and stop that re-entry circuit before it can even get started. And beyond meds, we have two really powerful high-tech options. You have ICDs and ablation. An ICD is basically an implantable defibrillator. Think of it as a 24/7 safety net. It's always watching the heart, and if it ever sees one of these deadly rhythms, bam, it delivers an internal shock and saves a patient's life. Catheter ablation, on the other hand, is a procedure where we go inside the heart with a thin wire, find that exact short circuit we talked about, and essentially cauterize it, trying to get rid of the problem for good. So let's wrap up management. The key points are this. If your patient is unstable, the answer is an electrical shock. Period. For long-term care, you have to treat the underlying disease, use the right medications, and for those high-risk patients, an ICD is the ultimate life insurance. All right, in our last section, let's look ahead a bit. How can we actually prevent these scary events from happening in the first place, and what are the big picture ideas we need to walk away with? Prevention is absolutely huge. Sometimes this means putting an ICD into a high-risk patient before they ever have an arrest. We call that primary prevention. It also means being super aggressive about managing things like coronary artery disease and heart failure. But just as important, it means asking about family history. An unexplained death in a young family member? That is a massive red flag for a possible inherited syndrome that needs to be investigated in the rest of the family. And that brings us to our final takeaway, which is really a question for you to think about. We've come back to this one central idea again and again. The underlying heart. It doesn't matter if it's a scar from a heart attack or a genetic problem with an ion channel. You can't just treat the rhythm on the screen. You have to understand and you have to manage the patient's specific heart condition. The arrhythmia is just the symptom. The heart itself is the disease. And understanding that, well, that's the key to everything. Thanks so much for joining me.